वीडियो करो
the patient. So this is a case scenario of a patient.
মোবাইল ধরেন না
Patient is hypertensive and smoker. He is a 65-year man hailing from Odisha, presented with the complaints of right-sided
cameraman boshen
for last 8 months. It is insidious in onset. Initially, it was 1 by 1 centimeter and gradually increases the size to attain the present size of 3 by 3 centimeter. There is no history of skin changes or discharge from swelling, no history of pain, over swelling, fever, sore throat, chest pain, cough, voice change, dysphagia, respiratory distress, hemoptysis, otalgia, and there is no history of weight loss also. Patient has a history of decreased appetite, his bowel and bladder habits is normal. General survey. Patient is well nourished, well hydrated, general examination is normal, and all the vitals are also normal. On examination, a globular swelling in right upper part of the neck at level 2 is about 3 by 3 centimeter, hard in consistency, smooth surface, well defined, not fixed with underlying skin, overlying skin and underlying structure, does not move on swelling or protrusion on cuff. Indirect laryngoscopy, other ENT examination and systemic examination reveals normal. So this is the scenario of the patient. What H. Martin says, he says an adult patient who presents with a palpable lateral neck mass, whether solid or cystic, should be considered to have a metastatic lymph node until proven otherwise. So with this presentation, I like to ask the panelists, do you want to go any further clinical evaluation? Professor Abu
First, we miss the oral cavity. We have need to examine the any protrusion of the.
There is nothing significant in the examination.
But you are not mentioned it.
Sir, sorry, sir, I mentioned it. Indirect laryngoscopy, other ENT, and systemic examination reveals normal. That's right.
No, I see the patient, but it may also push the oral cavity. It is the
Okay, sir.
examine the oral cavity and
Professor Abu Yusuf said that
and also palpate the oral cavity.
Yes. So palpation and examination of the oral cavity will be considered. So
Mohammed, I want to share one thing. Professor Abu Yusuf sir mentioned is 100% correct. So digital palpation, the examination, no ENT patient examination will be completed without digital palpation. So thorough clinical examination and examination under proper headlight, examination of the oral cavity, oropharynx, and base of the tongue, and especially tonsil by digital palpation.
okay, Azad, we got the point. We'll do the digital palpation and oral cavity examination.
Also examine the carotid artery pulsation.
Okay, carotid artery pulsation is got the point. Mito, you want to do any further clinical evaluation?
No clinical evaluation. Usually, sir, আমরা fiber optic laryngoscopy.
Exactly.
Office laryngoscopy.
Exactly, that is the point. Office scopy is the examination.
Fiber optic nasopharyngeal laryngoscopy, sir.
Yes.
Nasopharynx का हमने.
So the patient, a fiber optic laryngoscopy report is normal. Mito rightly mentioned, to exclude the importance on the nasopharynx, the term now used is fiber optic nasopharyngeal laryngoscopy. So to include it in the nasopharynx is a very important.
বেজ অফ দ্য টার্মটা কি ভালো মনে হচ্ছে এটা ইভ্যালু করে যদি ওর সামনে একটা এটা বলতে হবে দেখে বলতে হবে পালপেট কারণ ওখানে তো ডিফেক্ট করে বলতে পারবে না দেখলে মনে হবে যে এটাই মহিলাদের তো আসে যাবে
Now
Also tympanic membrane. There may be OME. There may be nasopharyngeal carcinoma.
yes, we discussed about it that the other ENT examination is normal. So now fine needle aspiration biopsy, core biopsy and open biopsy. Should the panelists tell about the fine needle aspiration biopsy, when to do core biopsy and when to do open biopsy? Will you please include? Don't you call me to? What should I say from the jury panel in the audio?
Other lymphatic.
Other ENT examination covers all these things and other systemic examination. that was normal. As a whole, in a term, I included it. Indirect laryngoscopy, other ENT, and systemic examination. I included it.
But
Dr. Saurabh, will you tell about what information do you want to get from fine needle aspiration biopsy, bone biopsy, when to do the open biopsy?
From finding a aspiration biopsy, we can guide us whether it is metastatic or not. This is almost we find that it is common carcinoma. So it may help us. And
Metastatic.
finding a aspiration biopsy, despite this process, then we can do more biopsy.
Okay, so from head neck histopathology, I like to ask Kasima
আমরা তখনই যাব যদি অ্যাডাল্ট পেশেন্ট হয় সে যদি সেক্সুয়ালি এরকম হিস্ট্রি দেয় এবং ওরোফেরিঞ্জিয়াল যদি কোনো আমার ইয়া মনে হয় সাসপিশিয়াস ওরোফেরিঞ্জিয়াল টিউমার
Fine needle aspiration cytology, we can mention it whether it is metastatic disease. But tissue diagnosis is necessary for further investigation.
So how much effective is fine needle aspiration cytology? There is a cystic mass, there is a solid mass. In your perspective,
কিন্তু আলট্রা একটা করা লাগে
efficacy and effectiveness of the
আলট্রা গাইডেড
which is important.
ওটা গাইডেড
When will you
বড়
advise
বড় ছবি দেখা যাচ্ছে
If ultrasound study reveals that it is a cystic node, then ultrasound guided fine needle aspiration
আলট্রাতে
cytology.
সলিড সিস্টিক দেখবেন
Well,
মার্জিন দেখবেন
So fine needle aspiration psychology is an investigation that is a very important investigation. It gives more than 80% of the information regarding the metastatic lymph node, and repeated FNAC is possible, and multiple directional FNAC is possible. So I like to ask Dr. Azad, Colonel Azad, tell me when will we go for open biopsy and why?
Actually, fine needle aspiration cytology (FNAC) can tell us more than 80% is okay, but sometimes they cannot tell whether it is squamous cell carcinoma or adenocarcinoma. It is a dilemma. Then there is the option of core biopsy or two-cut biopsy.
When
Take
will
some
we go for
tissue.
open biopsy?
Open biopsy. If core biopsy is not also
Open biopsy is contraindicated.
cannot say it is a tissue, nature of the tissue is it is squamous or adenocarcinoma, then open biopsy. But there is a debate. Open biopsy is done or not done. There is a study.
Professor
But
Imamoti.
nowadays it is optional. It is not done.
Thank you. Actually, but as you said, you're talking about the lymphoma. If the FNAC shows substance of lymphoma, definitely go for the excision biopsy, lymphoma, number one. Now, you recorded the FNAC report, they say squamous cell carcinoma. But okay, we'll go for the upper this thing. Go for the other studies like P16 positive or already.
Sir, we'll come for it later on. We'll come for it later on.
One minute, one more.
So, open biopsy.
One minute. Sometimes there is confusion between undifferentiated carcinoma and lymphoma, as Muthin sir said. In that case, it is very important to go for open biopsy.
But what American Association for Head Neck Surgeons guidelines say, they say when to do an open biopsy of the neck becomes extremely important, since we have no guarantee that primary will be located during the work. So if we do for open biopsy, in that case, incision line is very important. We have to give the incision line for further treatment. So I think we conclude this.
Okay.
Will you
এই পেশেন্টটা স্যার এফএনএসি হয়েছে স্যার ওকে আমার একটা কথা হলো এফএনএসি তে আমরা ডায়াগনোসিস আমরা সেল দেখবো অনলি সেল দেখবো এফএনএসি কোন টাইপের সেল এটা আমি দেখবো এখন এফএনএসি যদি আমাকে গাইড না করতে পারে আনডিফারেন্সিয়েটেড বলে অথবা পোরলি ডিফারেন্সিয়েটেড বলে
let us see.
দেন আমি কোর বায়োপসিতে যাব
Next slide.
Immunohistochemistry, immunocytochemistry may lead us.
Abul bhai, we will go for that thing. Please, we will ask.
Mamu,
We'll go. So these patients,
Mamu, I'm not pretty good.
metastatic
আরে থাম বলতেই দেয় না ঠিক আছে
এখানে hard. So why we think the lymphoma? Lymphoma never hurt. Lymphoma lymph node is disputed, mobile, rubbery, the syphilis. your lymphoma. Lymphoma in the consistency bhang.
Okay, so in this patient, the FNC report comes, it is metastatic only differentiated carcinoma. We do not do, it is our responsibility, we do not do any open biopsy or any core biopsy in this case. So with this, we proceed further.
Sorry,
Next.
Babur. Yes, sorry, Mamun.
Yes.
The report was, did they mention anything squamous cell carcinoma or any other carcinoma?
No,
Only this.
the report
No, no,
is
sir,
only
no.
metastatic
Only poorly differentiated, sir.
So next, so we have done imaging. We have done ultrasonogram. There is a scope of cross-sectional imaging, that is CT scan and MRI, and there is also metabolic imaging, that is PET-CT. Now, from the audience panel of jury, I like to ask Dr. Mahbub. So, on surgical point of view, what are the information we want to get from ultrasonography? The head neck imaging specialist is here. So give us a brief and what you want from our part, from surgeon part, that how we will advise the case of ultrasonogram or a CT and MRI. PET-CT will come later.
First, ultrasonography. Usually, ultrasonography. I will search for here. I will search. Okay, sure. I will search here for first the lymph nodes, the thyroid gland, the parotid gland, the submandibular gland. Sometimes large lesion in base of the tongue or in oropharynx or in larynx or hypopharynx, mid-line lesion. We can also identify in ultrasonography, but cannot differentiate that that is base of the tongue lesion or tonsillar lesion or hypopharyngeal lesion. This why, but in ultrasonography, the characteristics of the lymph nodes, whether it is rounded, it is solid, hypophytic, the margin is ill-defined, there is some calcification. So we can identify this by the
CT and MRI.
and then I go for CT scan. CT scan, specifically larynx. I ask my radiographer to do upshift technique to look for the.
Okay, with the relation of the blood vessels.
We must do the contrast.
Exactly. Sir, let me ask one question.
No, sir. Up to me.
What advice you want to get from us? What are the history or something? Most of the time, what we do, we write down the ultrasonogram of neck, we write down the CT scan of neck.